Hi, welcome to the pre-work for the Million Hearts Learning Lab using self-measured blood pressure monitoring to improve maternal health equity and reduce maternal mortality. The presentation you are about to hear was excerpted from a session by the same name at the 2023 Community Health Institute in San Diego, California. You will hear Dr. Ukachi Amerwa provide a brief overview of maternal mortality and hypertension in pregnancy. A QR code to register for this session will be available at the end of the presentation, or a link can be found in the description of this video. Thank you.
Thank you for inviting me here to speak today. This is a topic that's also near and dear to my heart. Just a little bit of a brief introduction about who I am. I'm Nigerian American. I'm originally from Southern California. I'm board certified in OBGYN, and I'm a maternal fetal medicine specialist. So I specialize in high-risk pregnancies. And as you can see in very, very tiny font on that slide, I'm also a women's reproductive health research scholar, which means I spend about 75% of my time doing research, and hypertensive disorders of pregnancy are the focus of my research. So for many reasons, I'm very glad to be here to speak to you guys about this today. And I have the large task of summarizing maternal mortality and hypertensive disorders into 15 minutes. So I'll try not to include too many pleasantries and just go ahead and jump right in. So just a quick overview of where you can expect this talk to go. I want to talk about the problem, what we mean when we're talking about maternal mortality, because you have to know what definition we're using to compare apples to apples and oranges to oranges. And then we'll talk about what's really a crisis here in the United States with regards to maternal mortality. Some of these statistics might be very familiar to some of you guys. Some of them might be very new, and they're very important for us to understand the landscape so we know what we're trying to tackle here. Then I'll shift gears to talk about hypertensive disorders of pregnancy, so we know what we mean when we talk about these disorders. And very importantly, the fact that, we think about pregnancy as the high-risk state, but pregnancy doesn't end with delivery. So what do we know about postpartum hypertension, hypertension after delivery, and what the problem is that's growing in that sphere. And then finally, I'll do a brief little intro into why pregnancy is so important to lead to the health of birthing people beyond pregnancy. So again, what do we mean when we talk about maternal mortality? And like I said, when you look at these numbers and these statistics, if you don't know what definition or what term they're using, you can be misled when you're making some comparisons. So maternal mortality is probably what you'll hear the most commonly, and that's any death during pregnancy or within the 42 days or 6 weeks, the traditional postpartum period after, that is related to pregnancy. Then within maternal mortality, you might hear people talk about pregnancy-related mortality, same pregnancy, deaths due to pregnancy that are during or up to a year after. And then finally, less commonly, but occasionally you might hear pregnancy-associated mortality, which includes pregnancy-related mortality and thereby maternal mortality. And that's because that relates to any death that occurs during pregnancy or within the 1 year after that is or is not related to pregnancy. So now that we kind of have an idea of what some of these different terms mean and what these numbers mean when we see them, I want to look at the U.S. maternal mortality crisis. So death from during pregnancy or within the 6 weeks after that's related to pregnancy. This graph should be really striking once I explain to you what is going on. What this is showing is the trend in pregnancy-related deaths, so up to a year after, within the United States from 1987 up to 2019. And as you can see, it's rising and has continued to rise beyond. In fact, the United States is the only high-income country for which maternal mortality is higher today than it was in 1990. So now we're coming on 30, going on 40 years with a continuing trend. And this is why we call it really a crisis. Now, you could ask yourself, is this something that's just happening in the world, something that we can't avoid, something that, global warming, like maybe it's a factor of something that's going on around us that's beyond our control. So is this a United States thing, or is this something that's happening everywhere? And the fact of the matter is, it's certainly something that is unique to the United States. So I don't know that my pointer works here, so I apologize to the people who are on virtually, but I'll use the laser pointer in the room. So on this graph on the left, you see this top line is maternal mortality or deaths per 100,000 live births in the United States. And down here below, we have every comparable high-income country. So it's devastatingly higher in the United States and has been on the rise. You can see some of these countries down here, European countries, some Asian countries. There have been a little bit of a bump. This is around the COVID-19 pandemic when many countries suffered a change in their maternal mortality rates, but the United States has just continued this uptrend at a much higher rate than all these other countries. And you cannot talk about maternal mortality in the United States without talking about disparities. And if you turn to this graph on the right, what you see is, again, all these high-income countries lined up, and this darker green line towards the very right is the maternal mortality rate in the United States. Now, if you parse out maternal mortality in the United States by race and ethnicity, you see these two bars to the left are U.S. Hispanic women and U.S. White non-Hispanic women. And then on the very right, you see U.S. non-Hispanic Black women. And so if you were to take out U.S. Hispanic Black women from the maternal mortality rate, I mean, it's still higher than these other countries, but slightly more comparable. And truly, the gap in maternal mortality by race and ethnicity is truly unfortunate. So I think I'm going to take just an additional couple minutes to talk about the disparities in maternal mortality at the risk of having to skip a couple things later, because I think that's a really important feature of the United States crisis. So again, here, just briefly, you see the U.S. maternal mortality, this is from 2018 to 2021, rising in all women, but significantly higher in non-Hispanic Black women and continues to rise tremendously. I will point out that Hispanic women, and again, this not taking into account the differences in vulnerability by immigration status, primary language. So we've kind of lumped Hispanic women here together, which is not fair. But originally the rates were quite comparable to non-Hispanic white women. And I will point out that with the COVID pandemic, we did see a stark jump in maternal mortality rates in Hispanic women, which point out the vulnerability of that population for many social and socio-demographic reasons that contribute to maternal mortality. Now, the reason disparities are really important to talk about is because when you think about high-income countries and all the technology and all the advancements and the medical advancements, you would think those things should help in tackling maternal mortality. And the state of disparities in the United States allude to some of the reasons why that alone is not enough to tackle this issue in the United States. And so I'm going to explain this graph on the right, which will point out some of the reasons socially why our maternal mortality rates are suffering. This looks at the maternal mortality rates by race and ethnicity divided by years of schooling completed. So to the very left, we have less than high school, and to the very right, we have college graduates or higher. And as you see, with less than high school, the rates are lowest in white women compared to Black and American Indian, Alaskan Native women, who have much higher disparities. And then when you get to college graduates or higher, that 3 to 4 times rate of pregnancy-related death jumps to about 5 to 6 times. And what's, all maternal deaths are devastating. No maternal death should be acceptable. So it's not to say that, it's acceptable that we have any death even if you have a less than high school diploma. But the reason I point this out is because we do this thing in medicine and in health where we say, okay, maybe the solution to improving health is to educate people, to tell people about what their risk factors are, to, improve their understanding of disease and treatments. But when we look at the trends according to education, that highlights why that's not the issue. And when you look at the disparities between white and Black women, it's really actually not that the rates for Black women are getting significantly higher as you go up higher education attainment. It's that educating people, as it should for white women, actually improves maternal mortality rates, because there is some element of teaching people about what we need to protect our health. But for Black women, it doesn't have any bearing. It has no impact. So what that means is the factors that we think are typically protective for health, better financial status, better educational attainment, while they do have impacts on certain parts of the population, are not having any impact when there are certain social factors, discrimination, racism, that may play a role in health. So sorry, I know I took a lot of time on that, but I do think that's really important in the scope of maternal mortality in the U.S. Just a brief note on maternal morbidity, only because it's important to note that death is not the only thing we care about when it comes to health, right? There are things that can affect your health beyond just not living, that can affect your quality of life. And so in obstetrics, we call that severe maternal morbidity, which are consequences both short and long term that can affect your health. Transfusions, sepsis, or infection that affects the whole body and your organs, heart failure, cardiac arrest or heart attack, kidney failure. And these have all been on the rise over the past couple decades as well. So truly a crisis. Now, why are we lagging here in the United States compared to these other high-income nations? One I pointed out, and we spent a lot of time on already, disparities. But there are some other things that we can point out. One might be aging, right? Now, this is not something that's unique to the United States, but as technology has improved, we've had the capability of having children later. And so when you look at maternal mortality for under 25 and 25 to 39, significantly lower than 40 and over, which are becoming an increasing part of our reproductive population. Part of the reason, I'm going to skip this really quickly, but this just shows that that disparity is also has racial and ethnic disparities as well. So the death rates with 30 and over are significantly higher for American Indian, Alaska Native, and Black women compared to white, Asian, Pacific Islander, and Hispanic women. Part of the reason that we see this is because some of the conditions that you get just from aging, high blood pressure, diabetes, those conditions increase just at baseline as we get older. And so this graph just shows that each of these conditions, the percent of live births that occurred in women who had hypertensive disorders, diabetes, increases over time because we are aging, and that complicates pregnancies and can certainly put us at higher risk of death. Now, this might be one that's really important because it puts us in the context of other high-income nations that we pale in comparison to. Our care access and our care structure in this country does not serve our birthing people the way it may in other countries. So you just look at the workforce, for example. The number of midwives and OBGYNs, first of all, is significantly lower in North America overall. And importantly, the proportion of midwives to OBGYNs is very low in the United States. Midwives are a cornerstone of birthing care, and traditionally, OBGYNs were actually brought in to take care of high-risk pregnancies. It changes some of the philosophy about how we take care of pregnancies. So some of that may contribute to what we're seeing in the differences of care and the differences in outcomes. How we allow for our birthing people to recover and function in their lives after they give birth. When you look at this graph of paid maternity leave in these high-income countries, Switzerland, which is the lowest here, is 14 weeks. The United States gives 0 weeks of paid maternity leave. And so that tells you where things stand in terms of our priorities and taking care of birthing people. Delivery, care after delivery, and postpartum care. All these countries provide by their national insurance, visits by midwives, public health nurses, some kind of practitioner after delivery. And depending on your insurance, depending on some state coverage in the United States, you may get access to some of those services. Otherwise, you're more or less on your own, aside from what you can get with your in-person visits. Now, to know how we can tackle this problem, we should really take a look at when and where and how these are happening. And I point that out because, like I said, traditionally we think of pregnancy as a high-risk time if you're going to have complications. But when you look at these 9 months of pregnancy and the day of delivery, and then you look at after birth, which we traditionally even thought of as 6 weeks, but really these deaths are truly happening up to a year out. So 50% of births are happening deaths are happening after birth. And that's really important for us to pay attention to, especially keeping in mind what I just talked about with regards to care structure and care access after delivery. I'll breeze through this a little bit, but you can find many graphs anywhere about the causes of pregnancy-related deaths, of which we're going to focus on hypertensive disorders of pregnancy. About 9% of the percentage of deaths in the United States, and that number can jump up depending on structure, access, and importantly, sorry, I think I jumped ahead for a second. Again, hypertensive disorders of pregnancy are one of those causes that the day of delivery and after delivery are where it really manifests in terms of the risks for birthing people. Just so you understand, when we talk about hypertensive disorders of pregnancy, I think the most common thing we talk about is preeclampsia. And so for those of you who aren't familiar with the definitions, this diagram just kind of outlines this group of disorders which fall under hypertensive disorder of pregnancy, of which preeclampsia is one of them. Preeclampsia is essentially hypertension in pregnancy, and I know one of our talks will go in a little bit of depth about what preeclampsia is, that we see manifest as of 20 weeks of delivery and should resolve by 6 weeks postpartum. That doesn't even capture people who have chronic hypertension or hypertension before pregnancy or before 20 weeks that affects them throughout their pregnancy and beyond. That doesn't include superimposed preeclampsia, people with chronic hypertension who then get the organ complications from preeclampsia, and even people with what we call de novo postpartum hypertension who have no blood pressure issues prior to delivery and then have an onset of high blood pressure and preeclampsia after delivery. And this is a group of people who previously were kind of understudied and neglected and we're realizing are really at high risk. I'm going to skip this just to say that it's important to know that preeclampsia is not and hypertensive disorder of pregnancy are not quite the same as hypertension outside of pregnancy, right? It's not reduce your salt intake and exercise and you can get it to go away. Unfortunately, this is a placenta problem, right? There's a certain way the egg and the sperm comes together, part of which is the placenta, that buries itself into the uterus. And if it doesn't set up properly, it releases all this inflammation into the mother or the birthing person's system that causes effects on your blood vessels, high blood pressure, your kidney, your liver, the brain, to lead to seizures. So monitoring people and really watching out for signs and symptoms sometimes is all we have because we don't really have the tools to prevent it, so to say. I think I come around to this, so I'll skip this slide for a second, and I'll just jump really into our understanding of how postpartum hypertension is also a growing problem. I mentioned that 50% of maternal deaths happen after delivery. When it comes to hypertensive disorder of pregnancy, we're actually at 70% of those are happening after delivery. So it's not only a case of monitoring before, but keeping people looped in afterwards. And the reason this has been somewhat difficult is because historically, as we know, the care paradigms in pregnancy are you have your every 4-week visit, every 3-week, every 2-week, every 1 week, you deliver, and then 6 weeks after we see you. And that's a long time to go without any monitoring and any touch points with your provider. And on top of that, one thing I love about pregnancy is people will do just about anything to take care of the baby that's growing inside of them. They come to all their visits, they'll follow all the testing, all your recommendations. After they give birth, they also will do everything to take care of the baby that they just birthed, including that means neglecting themselves or not being able to go to their own visits. 40% of people don't show up for their postpartum visits, and that number is even larger where access is more difficult. So for many of these reasons, we've started to use digital engagement tools, technology as a means to help facilitate care for people such that it fits with the structure of their lives and doesn't cause additional burden. Pregnancy is really an opportunity for us to tackle long-term problems. I always tell people pregnancy is a stress test. Your lungs get compressed, your blood volume increases, you have more blood cells, everything changes with your kidney function, the way your liver processes things. And so any problem that pops up during pregnancy really is a sign of what could come later. Because you know what else is a stress test? Aging. So when we see what happens in pregnancy, it's important to note that these are things we should take account of and follow these people throughout their lives so that we can help people lead healthier, longer lives. So pregnancy and after pregnancy are really important to kind of reduce the risk. And one of the main things are early monitoring, early visits, watching out for signs and symptoms, and treating people when we see them get to very severe rates of hypertension. Sorry to rush through some of the last slides, but I think I touched on probably the grand overview of what I think is probably really most important to learn about hypertensive disorders in pregnancy, and I look forward to questions afterwards.
Thank you for listening to this pre-work video for the Million Hearts Learning Lab, using self-measured blood pressure monitoring to improve maternal health equity and reduce maternal mortality. At the live session on January 11th, you will have a chance to ask questions from Dr. Ukachi Amarawa, Eleni Sigas, and Dr. Lisa Green. Please keep your eye out for an email with a link to a survey to collect your questions once you have registered for this session. We look forward to seeing you on January 11th.